presenter is Kim Ward. She's going to be presenting two topics for us. The first is, so Kim Ward is Associate Director at the Duke Cancer Network, and she is going to be presenting eligibility, and then after that, routine AE reporting. So please join me in welcoming Kim Ward.
Oh, here, this works. Use that guy. Oh. I'm going to use the clicker, so everybody get ready. It should be fun. Welcome. We're excited to have everybody here, following everybody's lead about being in person, which is super exciting. And welcome to everyone who is joining us virtually. So we are going to talk about checking eligibility and the kind of tips and tricks and the good practice. And I'd like to thank Jen for the slide deck and helping out developing that and reviewing them for me. So the objectives, we're going to talk about why is it important to confirm eligibility. We're going to talk about some steps, how to build a process, have consistency, how to avoid some of the pitfalls, and what documentation do you need to show eligibility, and how you determined your eligibility. So why is eligibility a big deal? So it's a big deal because of patient safety. It really helps us determine the appropriate treatment options for the patients, looking at data, and then also really deviations are in the details. So typically when you find deviations, it's in the detail, you miss a detail from the eligibility. And we're going to talk about some of those pitfalls. So where do you go for eligibility documents? So that was a great segue that we just listened to about the sections of the protocol. So you see here, we have the eligibility criteria, which is section 3, study calendar is always going to be in section 5, and so forth. This is really important because it talks about this is where they're going to be. I had an incident where somebody was asking a question and they referred to the page number of the protocol, not necessarily the section. And then the person responded based off of the page number, and it just caused confusion. So like when you're talking or you're writing an email, asking questions, I encourage my team to refer to the section of the protocol where they're getting that information from versus like the page number, because everybody prints it differently. So at the beginning, it's really important to standardize your process. So identifying your institution's process, and this really just helps ensure that you're not missing any steps and that you have everything completed. And really, I like this graphic here about consistency is key. So doing it consistently the same way by your policy and procedure is really key and will help you determine eligibility. So we have some examples in here about the details, the small steps to help you determine eligibility. These are just some examples that, again, like Jen and I came up in regards to checklist. And if you have a checklist that you use, does anybody use a checklist now? When not the eligibility, but maybe you have a checklist about the things that you have to do for eligibility in terms of like sign off, all the systems you have to put it in, what do you do with the consent, that type of thing. Okay, saw a few hands go up, great. So this is one example about a checklist here, and this is showing that it has to be completed prior to randomization. This is another example, and again, it's all about identifying the process and standardizing it. And you can see here, this is like an NCTN eligibility checklist that a site has created. So what to print when you're working up a patient eligibility? I can't stress this enough. If this is the only thing you take out of this, is you want to use the current version of the protocol. So you'll see this in the slide deck. We'll talk about this quite a bit. It's not recommended to print consents and print protocols and have a stack somewhere, because it's just, you got to version control them. And if their amendment comes out and you're not operating from the current version, it could lead to a protocol deviation or ineligible patient. So what we recommend is that you use the eligibility from the body of the protocol, and just print out those pages. I like to, probably not the most friendly thing, but I like to print and write. I don't do well when it's all electronic. So I'll print the 2 or 3 pages of eligibility, write all over it, and that kind of thing, and use it for to work through that. Also, the other important thing too, which a lot of people don't think about, is the stratification factors. We recommend that you're looking at those, you're printing them, you're keeping them with you as you're working through your eligibility, because when you go through that piece of it and open, it's important to have that information there so that they're stratified to the right arm. And also, if stage is a part of stratification, that's part of eligibility as well. So you want to make sure you have that right, because it will affect multiple things. And you want to document your notes and sources for each portion of the eligibility. We're going to talk about some of those examples. Some of the eligibility requirements will require multiple different source documents. So making sure that you have those things and referencing where it is. I like to think of it, when I started, I was told you want to be able to tell a story. You want to be able to tell the patient story in the chart. So when a monitor or an auditor comes in, or even another coordinator comes in, that they can pick up where you started or left off and really tell the story, and tell the story of how you determined that they were eligible for the trial. So this is an example about what I was just saying about writing on your eligibility checklist where you got the source from. So you can see here, the first one, we made note that there was no prior treatment, and we know that based off the MD note and the date of the MD note. We talk about the performance status, where we got it, the date of the MD note. So those are some examples there. I think that's really important, again, because it's telling the source. And if you can't sit there at elbow with the monitor or the auditor, they can look here and say, okay, I'm going to go to that note and verify that source, versus them missing it or looking at another MD note. So again, here's the kind of key take home point. You want to make sure you're using the current version of the protocol. And I do this as well. I print the test schedule and the footnotes, or that you're having it, because you want to make sure that you're documenting the dates. So it's kind of hard to see maybe a little bit, but in the green there, you see that we have listed the dates that these occurred, because we want to make sure that they occurred prior to registration and that we're in the window of time, because that is part of eligibility as well. This is an example of what the open enrollment form looks like in CTSU. You can go in, and it is on the CTSU website, and you can look at it, print it, can write it out, practice filling it out before you actually go into the open system. And then also in the open system, you can do like a trial, like a practice enrollment, so that you can see those questions that they're going to ask. I've done it multiple times where I've gone in and kind of got caught off guard, especially with stratification factors. You're like, oh, wait, I mean, it wasn't necessarily part of eligibility, but I need to know this, so they get stratified to the right arm. So then you're prepared. So when you go into the open system and do the live registration and randomization, you have everything that you need. I think it's a great tool to have and look at ahead of time. This is a randomization checklist. So again, this is an internal document. So if you have these internal documents, again, consistency is key. So knowing kind of what your process is and what do you have to do prior to randomization. Do you require a double check of eligibility? Do you have 2 CRCs or someone else checking eligibility after you reviewed it? How do you get your MD, your PI to sign off, or the treating MD? So just thinking about those things that you do prior to putting them in open and randomizing them. So we're going to talk about examples and documentation of source documents and kind of how to avoid some of the pitfalls there. So again, you're confirming the eligibility criteria. You're going to have your eligibility. You're going to have your test schedule and stratification factors in the protocol. And really, like we were just talking about, it's really ideal for the auditor to just view your source documents and conclude that the patient's eligible. So when you're writing that out, kind of helping them tell the story for them, and it's all right there in that baseline eligibility section of your chart or on your electronic drive, it really makes it easier for them to verify that eligibility. And again, you might have multiple sources to confirm eligibility. You might have a path report and labs and MD notes, and you might have multiple sources to prove like one eligibility. And we have an example of that. And you want to make sure that you're reading the entire eligibility point all the way through. And again, we're going to walk through an example of that. And here we talk about this pitfall about providing documentation just allows for easy confirmation and staff turnover. I don't know about anybody, I'm sure everybody in the room over the past 2 or 3 years has felt the staff turnover problem and issues that we're facing. And so this just really helps when you have it there and somebody can go in and pick up behind you. So here's an example about how a kind of a pitfall that has gotten, probably all of us at one point in time. So you see here this eligibility criteria 3.2. So the patients must have histologically or cystologically proven primary non-small lung cancer, et cetera, et cetera. I won't read it all to you, but you see there's 4 points. There's 4 things to prove for eligibility in that one section 3.2. So the first one is the patients have to have the histologically or cystologically proven primary. So that's number 1. So that would come from your pathology report or your cystology report. Then the next one is that the stage of the disease. So you want to go to that appendix where they're walking you through the staging. And then most likely the stage is going to be from like a radiographic imaging, CT, bone scan. Maybe it's a path report from a metastatic biopsy, or it could be all of the above. Then the next point is about the disease may be either newly diagnosed or reoccurrent after previous surgery or radiation. So again, MD note would be your source, and usually typically from like the initial diagnosis noting the treatment given or not. And then the last one is the patients with additional lesions, non-primary lobe without, depending on the stage. This likely doesn't require additional source because you probably already have it up there in the path report or the surgical note, but it does come into the staging. So you want to make sure that you have your staging piece right. And we're going to talk about staging because it can get a little tricky. Has anybody had any kind of experience with this where there's like multiple things in one section and kind of trips you up and kind of have to check each box, right? So again, another tricky point here is you see the example about the T&M stage. So there's a couple of things there about that you have to verify their ER/PR status and then their stage. So really, what do you think is a good, a good source documentation for staging? It may not necessarily be the MD note really shouldn't be your final source because we know a lot of times things are dictated in error, copy and paste, or maybe they dictated and an amendment came later and that MD note wasn't updated. So really looking at that T&M and staging really should come from the staging from your path report, ultrasounds, bone scans, whatever you're using to determine the stage. Another kind of tricky point is medical history doesn't match the medication list. I don't know about everybody else, but med reconciliation is a challenge. My sites are in the community setting and rural community setting, so patients are not great historians typically sometimes, or they don't remember, or they didn't bring their meds with them. So that can be a challenge. So really thinking through and getting that good baseline med reconciliation list at time of consent or eligibility will help you way down the road with data entry, adverse events, eligibility, all that stuff. So taking that time at the beginning is really helpful. This is, again, we talked about this a little bit. When you go into open, you want to make sure that your institution has the study open. It hasn't been suspended for some reason. And you can do that through your local process there of knowing what studies are open or not open. But then also in the open system at your institution, you can go to the CTSU, to the regulatory tab, to the site registration and confirm it. That'd be pretty bummer. You did all that work and study's not open and you can't enroll them. So a little more about detailed steps continued. Just thinking about are there any special requirements or training or credentialing when you're opening a protocol? So does the coordinators have to do ePro training? Or is there a type of assessment that the research professionals need to do, like the get up and go, the walk test, or maybe it's a cognitive test testing memory? So thinking about those things to make sure that your staff or your team or yourself as the coordinator is done that, had that credential checked off, and it's in there so that you can do that when it's time. And also you want to make sure that you're that you're getting your protocol documents, you're using your IRB, your internal database directly to and CTSU, make sure that you have the current version. So again, we talked a lot about these already. These are the documents that you want to pull together, make sure you have when you're starting your eligibility workup. So you're going to look at your open enrollment form, of course, your eligibility. You're going to look at registration, procedures, instructions. And I think this is really important. This kind of, will trip us up sometimes about how quickly the treatment must be initiated. This really impacts the timing of registration. Maybe and scheduling with patients, especially in our community sites, they have to travel and their third cousin can only bring them on Tuesday. So a lot of times I encourage the coordinators to print out a calendar and map it out on the calendar and count the days if they're a visual person so that they can see it that way on paper on a calendar. So I think that's really important to pay attention to. You want to make sure that you're reviewing your drug section so that you know when to order drug or whose responsibility is it to order drug. Does your pharmacy order drug? How do you alert your pharmacy that you need study medication? This is really important because if you register the patient and they have to be treated within 7 days, but it's going to take 14 days to get the drug, then we got a problem that we need to work through. So making sure that you're aware of that. And then also, I like to print the consent when I go consent patients. And I have my own copy and then they have a copy that they follow along with. And I write on my consent, highlight kind of, especially if it's the first time I'm consenting somebody to that study, just as I'm kind of learning the study. So I'm printing it, highlighting it again, making myself some notes so that I can make that process smooth for them. And again, you always want to make sure that you have the current version. So we put in here about staging because this can really trip people up in the eligibility process. So on your own, you can stage your patient. I think I'm a nurse, went to nursing school. So when I gave chemotherapy and stuff, it was really important that you did your own independent dose calculations. So then you didn't copy somebody else's mistakes, right? When you're, doing your dose calculations. And I kind of think of it the same way for eligibility. I really encourage my team and myself too, to do it independently. So it's easy to say, oh yeah, I see where you got that from. So you're not kind of copying or a mistake. And then I think it's also really important to talk through what your internal process is in regards to your MD, the treating MD or PI signing off on stage and verifying. Staging can be very tricky, especially depending on what disease population you're in. Sometimes it takes 2 or 3 people to kind of verify the stage. Maybe you need pathology to weigh in. So you also want to make sure that you're verifying protocol imaging that was completed. So what did they have at baseline? What are they going to get on the study? What does the study require? Maybe they had a CT at baseline, but the study requires something different once on treatment. So you need to think about those pieces as well. You want to make sure that you're reviewing all images for questionable areas and follow-up. And this again is kind of goes back to like the med reconciliation where you want to make sure you have a good list. Same thing for your target and non-target lesions. There'll be a breakout session later today about rhesus, but you want to make sure that you are knowing what lesions you're following, and so that you have that for your baseline data. So you're identifying your target, non-target, and again, what you're going to follow. We put this in here, just kind of talking about some different examples about where you're going to find some things. So for breast patients, you want to talk about, you want to make note of your pre-op physical. Is it inflammatory? Do they have nodes or palpable nodes? You want to make sure you're reading through the sentinel lymph node biopsy procedure really well. A lot of times that in the breast studies, that plays into their eligibility criteria or their stratification. So for a lung, you want to think about the level of nodes that were sampled. Did they have clear margins? What did the operative note mean? And what did it dictate in there regarding lymph nodes and sections and where we're at in the lung? Same thing for colon and rectal cancer. You knowing where it is, again, did they have a complete resection? Was there adhesions? Was there multiple areas? What did the pathologist kind of consider? Is it multiple primaries, one primary, metastatic? All that's really important when determining stage and looking at that for eligibility. And same thing for fish and hormone molecular testing, making sure that you have all the histology there to determine eligibility. So just wrapping up, think about things and review things that you cannot change early in the process. And we'll talk about that in just a minute. You want to, again, make sure that you're standardizing your process. We talked about this. Really encourage, don't store documents. Go to your internal place, print out your current version of your protocol and consents. You want to make sure you're having that open dialogue with your treating MD and PI. And then I thought what Mike Kelly said was really great. It's okay to email the protocol coordinator and the study chair to get them to weigh in. I strongly encourage you to email them so that you have it in writing and you have a date and time stamp and you get a response back. There's been times where I needed to call and talk through it with somebody else. And so we have a phone call and then I just, follow up with an email and say, just to recap our conversation, make sure we're on the same page. Because trust me, I won't remember what I said today. And I definitely won't remember in 3 years when Alliance comes for an audit, what that conversation was. So you want to make sure you have all that documented. Again, document your sources, where you found these things, and making sure that you have them. You want to make sure you're reviewing your stratification factors with the MD and document as needed. And then really good practice is to have the MD review. You want them to sign and date the eligibility from the protocol. And then if your process internally is that they review your checklist or your registration worksheets and the stratification factors, then you should make sure they're signing and dating that as well if that's your internal process. And then we put this in here just kind of about recent discoveries, talking about things where we've determined they're eligible and then something changes and they're not. So like the MD note stated in an email that the patient had an ECOG of 1, but then you notice that recent office note says that the patient had altered mental status, was found laying in the driveway and acting as though nothing was abnormal. So obviously something has changed and their performance status needs to be readdressed before you determine their eligibility. Eligibility criteria stated that there was no prior tamoxifen therapy, but the patient received tamoxifen. You have documentation of for 1 week, 2 years prior to enrollment. So that may not make them ineligible if they only took it for 1 week, but you want to get further clarification about that so that you can, again, tell that story. Why did they only get it for a week? And then it may require reaching out to the study coordinator or to the PI and the study chair, just getting that clarification, like he said, interpreting the eligibility and what you have. And then here, the early stage lung cancer study, the patient had a PET and brain MR, but after consent, after consent, they had an MRI that demonstrated metastatic disease, and the patient was enrolled to the early stage disease trial 6 days after the PET and brain MRI. So it's really important that you're going back, reevaluating the eligibility. So you determined they were eligible, they got consent, but then they needed something to finish up eligibility or registration, and something's changed. So making sure that you go back in and check that. Also, that lately we had an issue not too long ago where a patient met eligibility criteria based off labs, but then was out of the 7-day window, needed labs repeated. So the clinic got the labs on cycle 1, day 1, but then the patient wasn't eligible. That's a bummer. So making sure that you know your time frame, try to get them in if you can, and then also making sure that you have some type of stop mechanism so that, again, you're rechecking those eligibility criteria if they have to be repeated before they start treatment. Questions?
Great.
Or
Thank you for
comments? Yes.
pausing to speak into the microphone. The virtual attendees appreciate that.
Okay, my name's Kristen. I'm from Spartanburg Regional Healthcare System. I was just wondering, is there a specific section of the protocol that identifies, I guess, training for coordinators? I guess if there's any specific training in the protocol, which section is it in, if it's in any?
Yes. And you tell me if I would think it would be in the registration and where you get the information about registering them and how to register them. But I feel like I've seen it somewhere else as well. So I know, like, if you have to do ePro training, I have seen that in the section where about the optional study. So if it's optional and there's ePro or quality of life, and there's specific training about that as well. And then also, if you haven't done it, it'll show up in RAVE that you haven't done it. It'll be like beside the study that you have that training as well. So there's kind of multiple places. But if you get to that point in RAVE, it might be a little late. Like if you're already there to enter data or use it. So
Good question.
yeah, great question. Any other like comments or anything somebody would like to share about what you do for eligibility that's helpful for you or that you've learned or share with the group?
Just
Okay. All right. Well, you get to hear me again.